Now that we are familiar with the clinical presentation, the etiology, pathogenesis, and complications of pericarditis, let us look at what investigations would you do for a patient who comes to your clinic with pericarditis. Now, the investigations are threefold. So you can see that ECG, chest X-ray, and echo will provide you the most valuable information about it. Usually, the most easily available is the ECG. So, when you're going to do an electrocardiography, you will see changes during the early phase and late phase. So, let us now discuss how the ECG changes occurs in a case of pericarditis.
In order to understand the ECG changes in pericarditis, the first thing we need to understand is that the ECG changes in pericarditis are due to inflammation in the underlying myocardium, right? You know that ECG records the electrical activity of the myocardium. So naturally, it is the myocardial inflammation that leads to ECG changes in pericarditis. And you will also see that the same myocardial inflammation is responsible for mild elevation of troponin. So I will take you back to this diagram where I have chalked out the atria. Here are the ventricles, right? That is your left ventricle and right ventricle. So the ventricular muscle is usually much thicker than the atrial. I am sure you are aware of it, even though I have shown them pretty much equal here. Now, electrical activity of the myocardium starts at the SA node and first depolarizes the atria. The atrial depolarization, if you go back and have a look at our ischemic heart disease session, you will see that atrial depolarization leads to the P wave. After the depolarization of the atria, the electrical activity remains within the AV node for a short period of time. This is the AV nodal delay, also called the PR interval. AV nodal delay, PR interval. So let me recap that. Atrial depolarization, P wave, AV nodal delay, the PR interval. Following that, the ventricular muscle gets depolarized by the very rapidly conducting His bundle and bundle branches. This ventricular depolarization produces what is called the QRS complex. QRS complex. Now, a couple of things I want you to remember about this. One, ventricular depolarization comes from the AV node via the His bundle and the bundle branches. So, one thing that you can understand is that since electrical activity is being carried by the His bundle and the bundle branches, this electrical activity will first depolarize the endocardial area, the region next to the endocardium, and from there it will go towards the epicardium. So remember this, depolarization of the ventricle usually happens from the endocardial region towards the epicardial regions, right? Of course, it goes from the apex towards the base. The current flows from apex towards base, but very important, endocardium to epicardium, right? I shall not go over how the QRS is formed at this. We will be discussing that in our ECG sessions. So we have the P, we have the PR interval, we have the narrow QRS complex. Sorry for the overwriting there. And following that, once the ventricles are depolarized, all of you are aware that after that the ventricles contract. When the ventricles are contracting, there is only mechanical activity, there is zero electrical activity, meaning when the ventricles are contracting, there is no electrical activity, or if you do an ECG, that will produce a flat or isoelectric line. This isoelectric line is what we usually call the ST segment, and remember, there is no flow of current during the ST segment. Following that, we have the T wave, right? So we have a P wave, we have a QRS, we have an ST segment, and we have a T wave. Now, this is the normal ECG. Now, I would like to invoke the concept of the pericardium. You know there are two layers of pericardium. One is what we would call the visceral layer of pericardium. The visceral layer of pericardium, you cannot distinguish it from the epicardial layer. It is stuck very closely to the epicardial layer. So I shall call it visceral pericardium. And there is another layer of pericardium which is slightly above that. Okay, this is slightly above that, or just on top of it we have one more layer. Between these two layers we have very minimal amount of fluid. Remember, this is a schematic diagram, so even though I have shown you a lot of space here, there is really not much of fluid in the pericardium. Very minimal amount of fluid usually in the pericardium. This green color layer is what I will call the parietal layer. Parietal layer of pericardium. So there are two layers of pericardium, that is the visceral layer and the parietal layer, right? So we have two layers of pericardium, the visceral and the parietal layer. And remember, the visceral layer is almost the same as the epicardial muscle layer. Now, whenever there is inflammation between these two layers of pericardium, that is the visceral and the parietal, that is when the two layers of pericardium starts rubbing against each other. This is what produces the very classical pericardial friction rub on auscultation, which we have already discussed. And naturally, as these layers of pericardium move over each other, that will also produce the pain. Okay, we have already discussed those two concepts. Now, what is the correlate on the ECG? Remember that the visceral layer of pericardium almost is on top of the epicardial myocardium. That is just on top of the myocardium. That is what we call the epicardial layer of myocardium. So there is also going to be some amount of myocarditis. So remember, pericarditis is not just pure pericarditis, but there is some amount of myocardial inflammation, and that is why you will have both troponin elevation and changes in ECG. Remember, the ECG picks up abnormalities in the electrical activity of the myocardium and not pericardium. So it is the myocardial inflammation with relation to the pericardium that causes the ECG changes. So now observe carefully that this visceral layer of pericardium, which is very similar to the epicardial layer of the myocardium, okay, almost on the outer layer, okay. So this epicardial part of the myocardium, right, this is the outermost part of the myocardium, it is inflamed. So now it will behave the same as in myocarditis, that is, when the normal ventricular depolarization occurs. So if I quickly were to ask you which part of the ECG shows ventricular depolarization, you would say the QRS. Exactly, it is the QRS. When the regular QRS is happening or ventricular depolarization is happening, this red spotted areas that I have drawn, that is the epicardial part of the myocardium, does not depolarize. That's because it does not have enough ATP, because it is inflamed. At this point, all of the myocardium except the small thin strip of epicardial tissue will get depolarized. So that will produce the QRS. Okay, all this white myocardium depolarizing produces the QRS. Now all of them are positively charged. Okay. At this point, the ventricle starts to contract. That is, the ventricle finishes the QRS stage and goes into the ST part. While the ventricle is contracting in the ST part of your ECG, this red part, that is the epicardial myocardium, will now start demanding electricity, or will start demanding depolarizing charges to it. Now it is not yet positive, it is still in resting membrane potential. All the red areas are still negative, while this region is positively charged. So the positively charged region will now start giving current towards the negatively charged outer layers, or this will produce a flow of current from the endocardial to the epicardial surface, that is, throughout all parts of the ventricle, that is the anterior, lateral as well as the inferior. In other words, diffusely there is a flow of current from the endocardial region to the epicardial region.
So that gives us a diffuse injury current going from the endocardial to the epicardial surface, and at what point? After the QRS, that is, it flows during the ST segment. Whenever current flows towards the lead, it leads to an elevation or a positive deflection of the ST segment. So we are expecting an ST elevation. I'll show you side by side. So if this is the normal ECG, I will just show you the ECG of pericarditis. So we have the same P wave, we have the same QRS complex, which is not of great importance to us. We have the T wave here, and we are going to have an ST segment elevation. Remember, this is the ST and that's going to be elevated. Now, I would want you to remember that the area where there is going to be a injury current flow is at the epicardial region. And if I were to remind you, the depolarization of the ventricle starts from the endocardium to the epicardium. So as the flow of current is from the endocardium to the epicardium, the current reaches the epicardium at the very last moment only. So if you look at the ST segment as a point where the injury current can flow, if there was injury current flowing to the endocardial region of the myocardium, it would have been at this part. There would have been ST elevation here. This would have been for the middle part, and this is the part that is elevated for the epicardial part of myocardium. So, in short, since the current flows from the endocardial region to the epicardial region, if only the epicardial region is having an abnormal current flow or injury current, that will produce a deflection of only the last part, not the early, not the middle, because there is no injury current flowing in the endocardial region or in the rest of the intermediate part of the myocardium, but the injury current is limited. I think this picture would be, if I just remove these, you might be able to understand a little better that the injury current is limited to this small area of the myocardium. Okay, there is a flow of current only towards that small area of the myocardium. So there is going to be an ST elevation, of course, but it is only the last part of the ST. Okay, it is only going to be the terminal part of the ST segment. So there is an ST elevation compared to the normal. There is an ST elevation, but very importantly, since only the last part of the ST segment is elevated, the elevation is always concave up. Okay, quite obvious. Concave up. The upper part of the ST segment is concave. In case of MI and myocarditis, since the entire myocardium is usually involved, it will produce an elevation of the J point. The J point, if you remember, is the junction of the QRS complex with the ST segment. If this point elevates, you usually get the convex ST segment elevation. I will just show you a convex ST segment elevation side by side so that you understand what I am talking about. Okay, this is the P wave, this is the QRS. If we were talking about myocarditis or ST elevation MI, the ST segment elevation would have started from here, right from here. So it would look something like this. Right? As it is elevated like this part has to elevate. That gives you the classic convex up. Okay, convex up. The upper part is convex as compared to the upper part being concave. I would bring you back to the pericarditis. In pericarditis, we will have ST segment elevation, which is diffuse and concave up. Concave up. Okay, diffuse ST elevation, which is concave up. So this pretty much explains the abnormality that you see in the ventricles. Now, in case of myocarditis and ST elevation MI, the ventricles having the maximum amount of myocardium usually shows all the abnormalities in the ECG. But if you look at pericarditis, there is inflammation and abnormalities throughout the myocardium, usually in a thin rim of myocardium, not only in the ventricles but also in the atria. So atria
is equally affected as compared to ventricular myocardium in case of pericarditis. This is unlike in myocarditis or ST elevation MI, where the myocardium of the ventricle predominantly alters the ECG. In pericarditis, there will also be some atrial myocardial changes. So, even in the atria, after atrial depolarization, let me remind you, atrial depolarization is the P wave. After atrial depolarization, that is after P wave, classically the PR interval, this is the point when electricity is usually within the AV node. So there is not supposed to be any flow of current during the PR interval, yet because the peripheral part or the epicardial part of the atria is depolarized in a delayed fashion, that will produce an injury current. So now there will be an injury current flowing towards the pericardium. There will be an injury current flowing towards the pericardium and the epicardial part of myocardium, but that will be going from inside out, and that will naturally, in most of our ECG leads which are programmed to primarily look at the inferior wall, the lateral wall or the anterior wall, that is predominantly look at the ventricles, from those leads, whether it be lateral or anterior or inferior leads, what we will be seeing is there is going to be a flow of current away from the normal ECG leads, and this flow of current away from the leads will naturally produce a depression, and a depression will be during the part after the P wave. That is, the part after the P wave is the PR. So, in case of pericarditis, because of atrial depolarization or injury current in the atria, especially the epicardial myocardium, that will produce a PR segment depression. So, you will have a PR segment depression. PR segment depression. So these are the findings that you will have in early myocarditis. Diffuse ST elevation with concave up and PR segment depression are the ECG findings in early pericarditis. This corresponds to the point where you can hear the pericardial rub. This corresponds to the point where the patient comes to you with the sharp pricking pain. So those are the findings in early pericarditis. Let us see what would happen in the later stages of pericarditis as fluid starts to accumulate. Now look at the same pericardium as fluid starts to accumulate. As fluid starts to accumulate, this is probably in a week or two of pericarditis, as more and more fluid starts accumulating, at this point, the inflamed visceral and parietal pericardium are no longer rubbing against each other. So at this point, you will not hear a pericardial friction rub, neither will the patient feel the sharp pricking kind of pain. At this point, if you try to auscultate for heart sounds, they will usually be muffled. The ECG changes are also going to not be as well transmitted because the fluid is a poor conductor of the ECG waves, and because of this extra fluid having collected around the pericardium, the ECG findings in late stages is that compared to the normal P, QRS and T, you will have low voltage complexes. Low voltage complexes are defined as your QRS complex being less than 10 millimeters in the chest leads and less than 5 millimeters in the limb leads. Right? So if you have very small QRS complexes, that usually denotes that the patient is having a large amount of fluid around the pericardium. It is in late stages of pericarditis, low voltage complexes are the classic clinical finding on ECG. So with that, we have looked at the pathogenesis of ECG findings in pericarditis, and let's get on to the further investigation.
So you can see that the ECG changes vary with the early as well as the late phase of pericarditis. In the early phase, you see diffuse ST segment elevation. Notice how they are concave up. Associated with it, you will also see PR depression. So remember, diffuse ST elevation. So unlike myocardial infarction, similar to myocarditis, you're going to have diffuse ST elevation. Very important difference in pericarditis, unlike myocarditis and MI, the ST elevation is concave up. Concave up. Okay, it is usually associated with PR depression. So this is the early stage, and into the later stages, you will, as the fluid accumulates, you will see low voltage complexes, and you know the definition of low voltage complexes. So remember, depending upon the stage of pericarditis, the ECG changes will also differ. Now, apart from the ECG changes, the next important investigation that you do is a chest X-ray. Chest X-ray is useful in the later stages, especially as the fluid starts to accumulate. The heart takes the shape of a water bottle, or more specifically, a leather water bottle. Okay, so there's some cardiomegaly, and you will get what is called the water bottle appearance or the leather bottle appearance. Echocardiography. I have attached a link to a video which will explain the echocardiographic findings of pericarditis in detail. But as you can see in this screen grab from the same video, this is your ventricle. Okay, this is the left ventricle, the left atrium, the right ventricle, and the right atrium. Here you can see this large area of what we call hypoechoic or black colored on an ultrasound. That is, it does not reflect sound very well. Usually that is indicative of fluid. So you can see there is a large amount of fluid collection between the ventricles and the chest wall. Okay, so that usually indicates the presence of pericarditis on echocardiography.